So we've been giving 3 drugs for decades, and what joker, what comedian would start to think, oh, let's just change it all and go to double therapy? Really? I think what we're talking about here is not a new generation of HIV treatment. We're talking about a degeneration of HIV treatment. We're talking about couples, two drugs, and you think about any couple that get married, and when you start, if you wish them well, they have this honeymoon phase, they're telling each other sweet nothings, and everything's fine, and then reality sets in, and you have the later information coming out from the phase 3 studies, long-term rare toxicities. It's not looking so rosy any longer. So let's look at these drugs. And the other thing is about which drugs are you combining? I mean, what comedian would decide to combine Donald Trump and Melania? What comedian would decide to combine dolutegravir with rilpivirine? That's one of the most fragile, difficult drugs to use. Any mutation and it's finished. So let's look at the SWORD and Gemini studies. I think it's very, very important to state that in SWORD and Gemini, there is no difference, not just in efficacy, but there are more discontinuations for adverse events, more grade 1 to 4 adverse events for people taking dolutegravir or rilpivirine than people taking current treatment. So it's not only the same, it's actually worse in terms of safety. People they're going on quite nicely with their current treatment. You put them on to dolutegravir or rilpivirine, there is significantly more grade 1 to 4 adverse events, as with the other switch studies of dolutegravir. Dolutegravir is not sweeties. It's actually got its own CNS toxicity. And you look at discontinuations due to adverse events, more discontinuations. So you've got this new treatment that costs more money, it's branded, and it gives you more toxicity. Not necessarily a very good idea. And no improvement in efficacy at the same time. In Gemini, again, there's no difference in safety, there's no difference in discontinuation for adverse events. There are these differences in these really esoteric, subtle biomarkers of bone turnover. I mean, what are you going to say to somebody? Sorry, you had to discontinue your treatment because of CNS adverse events, but your markers of bone toxicity are looking just fine. I mean, it doesn't really add up. Now, the other thing is, let's avoid tenofovir. Tenofovir is this toxic drug. Let's have a dual therapy with no tenofovir in it. Now, if you look at all the studies where tenofovir was not boosted, and the problem with tenofovir is if you boost it, you get more toxicity. But if you look at studies where it's not boosted, it's just used with efavirenz or dolutegravir or in Hep B, there's no difference between tenofovir and TAF in terms of grade 1 to 4 clinical adverse events, laboratory, grade 3 to 4, serious, bone fractures, renal discontinuation. There's nothing there. So if somebody says, oh, let's go on to this dual therapy to avoid all this toxicity, show me where it is. Where are these bone fractures? This is based on over 3,000 patients in treatment. We've done the same thing for 23,000 people given Truvada or placebo for PrEP. Again, no difference. In all these safety parameters, there's no difference in the bone fractures. It just isn't there. Gilead keeps saying, oh, don't give tenofovir, you'll break all your bones. Well, if it hasn't happened in 23,000 patient years of follow-up, when will it happen? It seems like it's a bit of a lost cause, this just trying to blame tenofovir for everything. So I think this whole dual therapy thing, when a drug rep goes to a doctor and says, oh, look at my dual therapy, I've got all these amazing things. It's like this tale of the emperor's new clothes. He's told he's got this wonderful costume, and he walks out with his costume, and actually he's not wearing anything. There's no evidence that it's actually better. In fact, it's probably worse in terms of some safety parameters. People are trundling along very well on their current treatment. You put them on this new stuff, it can only get worse. Despite that, dual therapy was approved, and I think the dolutegravir rilpivirine indication was the most restrictive indication the FDA ever gave to a drug. So it was approved, but you have to have a baseline resistance test, you have to have low baseline HIV RNA, you have to have Hep B co-infection isn't allowed, there's no experience in pregnant women, there's practically no experience in Africa or lower middle income countries. What does that mean? Imagine you've got 100 people and you want to put them onto this dual therapy. Well, I mean, first of all, you could get more adverse events when you switch them, but secondly, what about the pregnant women? No clinical experience, Hep B co-infection. What if they've got prior VF? What if they've got no baseline resistance? And that's in Europe and North America. If you do try and do that in Africa, let's say you go to Malawi or South Africa and you say, let's switch all these people to dual therapy. Now there, nobody's got baseline resistance testing. A lot of people don't have baseline viral load, so you wouldn't know if it was above 500,000. A lot of pregnant women, a lot of TB. You just can't do it. It's just impractical. So dual therapy for most countries in the world, where most of the epidemic is simply a non-starter. There's no clinical evidence to back it up. So that's the first part of my talk. Now, the second part is more worrying. Now, this is what dolutegravir and bictegravir are doing to body weight. Now, it's very hard to get this information. We put it in a review paper. But if you look at the NEAT-022 study, there's a higher rise in body weight. It's a switch study. In the Spring 1 study, there were higher rises in body weight in the dolutegravir arms. If you look at the Gilead 1490 study, there was a rise of between 3.5 and 4 kilograms, both for dolutegravir and for bictegravir. But look at the bottom, look at dolutegravir monotherapy. All these studies are mainly in white men who show the smallest rises in body weight. And these white men given dolutegravir monotherapy, just in 24 weeks, they showed a 4.1 kilogram rise of body weight. Now, ViiV and Gilead have reacted to this, and they're rebranding their drugs. So this is the new brand name for, we've got dolutegravir, which is, it's got the new logo there, and an appealing set of sweeties underneath. And we also have biscuitegravir, which is these chocolate biscuits. So it just helps you understand the association with the weight gain, which is very noble of them, it's very kind. Now remember, the weight gains that I showed you, they were in white men. These Gilead studies, the ViiV studies, they're 90% white, 90% male, mainly white. Now if you look at women, they show much bigger rises in body weight on integrase inhibitors. This is data from Texas. And if you look at black people, they also show bigger rises than white people. So everything that you've seen in these studies of 3 or 4 kilograms, multiply that by 2 or multiply that by 3, and that's what we could be seeing when we look at black people and black women. So this is no joke. We're talking body weight rises in the region of 8, 10, 12 kilograms. Now, one of the answers to this is if you give tenofovir diet formula, this is another rebranding that's going on, tenofovir is actually associated with decreases in body weight. They're doing the deal with Diet Coke to make sure they've got streamlined branding. So if you look at TDF as PrEP, it's associated with weight loss over 5%. We've done a meta-analysis of all the studies. This was also seen in Discover, the PrEP study presented at CROI. It's been seen in the AMBER and the EMERALD studies comparing TDF and TAF. And there was a cohort study from Germany presented last year showing that if you switch people from TDF to TAF, you have a rise in body weight of 3 kilos. So basically, while dolutegravir is increasing weight, or bictegravir is increasing weight, tenofovir might be a counterbalancing force lowering body weight. Now, as a result, again, Gilead have changed their branding, and we now have tenofovir added fat. So that's helping along there. So it just helps you understand all these different terms. There's a lot of different confounding factors here. So if you put everything together, you've got these drivers of weight gain and weight loss. So people who are treatment naive, they gain weight. People on dolutegravir, biscuitegravir, they're gaining body weight, PIs to a certain extent, and tenofovir is acting as a counterbalancing force. And then women and black people are putting on body weight. So if you give a dual therapy of dolutegravir without TDF, the body weight's going to keep going up and up. And why do you not know this? Well, some pairs, some couples will deny there are any problems. And it sometimes catches up with them. And if you look at the whole development program of the ViiV studies, so in the in vitro toxicology, there was evidence that dolutegravir affected melanocortin receptors, which could increase appetite. Now, you've got 7,000 people in these studies, and body weight has been measured in nobody. So we don't know what the body weight rises are in the phase 3 program, despite this preclinical signal. Just a bit of a worry. So I think dual therapy really is a degeneration of HIV treatment. We don't have any efficacy benefits. The safety is the same or worse. We have weight rises on dolutegravir anyway with TDF that lowers body weight. If you give it without TDF, look at that study in Switzerland where the weight goes up 4 kilos in white men in 6 months. How much is that going to go up in black women year after year? These could be progressive rises. And the other thing about all these dual therapies, you can't use them unless you have baseline resistance testing. You really know that you're sure about that baseline resistance test, the baseline viral load, the Hep B co-infection, they're not pregnant. There's so many holes. This is such a restrictive population. So really, I think dual therapy, it's going to join the group of drugs in the past, you know, the Fortovase, the Nelfinavir, the T20. It's just going to be another one of those drugs where we're fond of it. You know, we mark it down in history, but really it's another one to consign to the history books. Thank you very much.